I am Dr. Francesco Pelliccia. I am an associate professor of cardiology at the University Sapienza in Rome, and I'm the head of the cath lab at the Department of Cardiosurgery. Actually, the background of our study was about the current guidelines on antithrombotics after the procedure, after the valvular replacement. And we all know that current guidelines recommend the use of single antiplatelet treatment. But despite this, we are aware that in the real world, clinical practice, many colleagues still use double antiplatelet treatment. That is the combination of an aspirin with basically clopidogrel or ticagrelor most of the time. So this is the current clinical practice. Also, we know that the current recommendations are mainly based on the results of a trial that have shown an advantage in terms of reducing the frequency of bleedings after TAVI, but no previous study has shown any effect of single antiplatelet treatment versus double antiplatelet treatment on mortality. So the aim of our study was to verify whether the two strategies can have an impact on the overall 6 months mortality after TAVI. Yes, I'm very pleased to present the TRITAVI Registry on behalf of the all the centers that have participated in this project that started more than 10 years ago in 2011. And currently there are 20 participating centers all from around Europe. And during this time frame, so in the last 12, 13 years, we have been able to collect more than 11,000 patients who have underwent TAVI. So we are very proud because this is a very big study population. And patient for this purpose of our study on the effect of antithrombotic treatment were selected if they had no concomitant indications to anticoagulation. Let's make an example of those who have a concomitant atrial fibrillation. In this specific case, patient should receive anticoagulants. But if there is no need for anticoagulants, all comers performing TAVI were able and discharged alive after the procedure were included in this real life registry. So we do believe that it's a very unique patient population that it's at variance with what is currently seen or included in clinical trials. We were able to review the data of more than 5,500 patients. We in more than 300, specifically 197 patients received single antiplatelet treatment, whereas 2,317 patients received at time of discharge double antiplatelet treatment. Most of the cases was the combination of aspirin and clopidogrel. All patients were then follow up for at least 6 months. The two groups did not show any difference in clinical feature, in presenting feature, no difference in procedural factors or procedural complications. So basically, the two groups were really comparable. And the primary point to our surprise was that those who were assigned to single antiplatelet treatment had a significantly lower overall 6 months mortality. So it means mortality for many causes, either cardiac and non-cardiac causes, as compared to those who were treated with the double antiplatelet treatment. And also those who were received single antiplatelet treatment show a significant lower incidence of cardiovascular death, a significantly lower incidence of no cardiovascular death. And also when we perform Cox multivariate analysis, this differences was confirmed, and the use of double antiplatelet treatment ranked as the most strong factor associated with a worse prognosis. The only other two parameters were left ventricular ejection fraction and the presence of a concomitant coronary artery disease. So this means that double antiplatelet treatment is really a negative predictor of overall mortality. Also, it's more important to underline the fact that patient with who had single antiplatelet treatment had, of course, as expected, a lower frequency of measured bleeding, but also a lower incidence of ischemic events. So this means that we do not use double antiplatelet treatment we fear that a patient is at high ischemic risk, because the ischemic events can be treated effectively with single antiplatelet treatment. And also we perform two other important sub-analysis, pre-specified sub-analysis. We compare patients, male patients with female patients, and the results seen in the overall population were confirmed either in men or in women. So in both groups, single antiplatelet treatment is associated with a lower 6 months of cause mortality. And also, this was an unexpected finding, we compare the effect of treatment in those who had coronary artery disease versus those who were without concomitant coronary artery disease. And in both groups, again, single antiplatelet treatment was associated with a significantly lower 6 months of cause mortality. So there is no need to use double antiplatelet treatment even in those who have had a previous coronary event. So I think that we need a paradigm shift, because still in our registry we observe that despite current recommendation guidelines that have been published in the last few years, despite that, many centers, tertiary referral centers throughout Europe, still using double antiplatelet treatment. There is actually a progressive decline in the use of double antiplatelet treatment, and this has been paralleled by decrease in mortality in the overall population in our registry. But still there is many groups believe that patients, especially in the first months soon after the TAVI procedure, are more somewhat protected if they are given double antiplatelet treatment. Our real life registry shows the opposite. So our colleague, interventionists, cardiologists, clinical cardiologists should refrain from prescribe double antiplatelet treatment, and single antiplatelet treatment is not only a strategy to reduce the risk of bleedings in this real high risk population, those who undergo TAVR, but in all the whole population of patients, because we can affect significantly the prognosis, because we can reduce mortality with the use of single antiplatelet treatment. Oh, thank you for this comment, for this question. Of course, our findings are derived from a registry, for real life registry. We are aware of the limitation of a registry. There is an inherent risk of bias of every observational registry. There are differences in baseline characteristics that we try to correct with the use of multivariate Cox regression model. Also, we face some missing values. So, I mean, there are some limitation in any registry. And so, actually, the ideal approach would be to perform a randomized clinical trial. So, our hope is that in the near future, a randomized clinical trial will be carried out in order to confirm, we think, we hope, the results obtained in our international multicenter registry.